Terminating hospice care, it can be terminated in one or two ways. When the client withdraws for any reason to receive treatment not covered in the hospice plan, or two, when the client no longer needs Medicare criteria. They no longer meet Medicare criteria. Those are the only two reasons we can terminate hospice care. Okay. Residential care. These facilities provide around-the-clock nursing care for clients who cannot live independently. This is a very costly facility. One, clients have exhausted their saving programs, such as Medicare, may pay their expenses. Once these people run out of money, I know it's sad to say, but they do make them find another source of coming up with how they're going to continue to get care. Usually that takes place in our long-term care facilities, so our nursing homes is usually where this happens at. Acute care. Acute care, this is a form of care that most of the expenses is for acute care provided in hours, days, weeks, or before the client's death can be significant. Providing terminal care. Nurses meet his or her basic physical needs for hydration, nourishment, elimination, hygiene, and positioning. So if you look at page 846, it will start with hydration. It is the nurse's job to check the client's swallowing reflex. Okay, if they're having problems swallowing, we're not going to give them anything to drink. Okay, because what happens if their gag reflex is not working? Right, they're going to aspirate. It's going to go to their lungs. Some say, well, what does it even matter if they're dying? It matters a whole lot. We still need to practice on dignity. Okay. Sucking is one of the last reflexes to disappear as death approaches. Eventually, the client may need intravenous fluids. Like I said, it all depends on the family members. If they want IV fluids, then we give them IV fluids. If they don't, then we won't. Nourishment. Some terminally ill clients have little interest in eating. Poor nutrition leads to weakness, infection, and other complications such as pressure sores. Consequently, the client may need tube feeds or total parental nutrition to maintain nutritional and fluid intake. If you look under nutrition notes, clients who are dying should not be made to feel guilty for not wanting to eat or drink. If they don't want it, we don't force it. You know, the older you get, the less you eat and drink anyways. So don't force somebody to eat. They might not be hungry. They might not have an appetite. So if they don't want to eat or drink, don't force them. But just because they tell you no doesn't mean we shouldn't follow back up in 30 minutes and offer another drink or eat. Just because they tell you no, it's still our job to go offer. Okay? Hygiene. Therefore, nurses strive to keep dying clients cleaned, well-groomed, and free of unpleasant odors. That's our job. Frequent mouth care may be necessary. Suctioning helps remove mucus and saliva from the clients that cannot swallow. So you'll see those clients with their lips are getting all dry and cracked, and they might be drooling a little bit. We can suction their mouth and then put some lemon glycerin swabs in there and make it moist. The appearance of that makes it a whole lot better. Nobody wants to come in and see their dying loved one lay there with saliva all over their mouth, or them look a hot mess and dirty where nobody looks like they even cared for them or took care of them. Okay, so make sure we're giving them a bath. Make sure we're keeping them clean and neat, along with the bed linens, just not the patient. We need to look at the whole picture there, okay? Positioning. We should be turning these patients how often?
Every 2 hours.
Every 2 hours, that's correct. If we don't, we're causing pressure ulcers. Us at the facility are still required to turn these patients. If not, we still get in trouble for it. The facility takes a hit for it if they get a pressure ulcer. Okay, that means Medicaid and Medicare won't pay for it if they get a pressure ulcer while they're on our watch. So we still have to turn them. Comfort. The goal is to keep clients free from pain, but not to dull consequences, suppress respirations, or inhibit the ability to communicate. Eventually, potent narcotics get involved. I think everybody knows that. Giving pain medications regularly and assessing pain level every 4 hours is mandatory of a nurse of a dying client. Okay, so just because we know they're dying, we still have to go in there and ask them if they are verbal. What's your pain level? Where are you hurting at? Because that should determine what type of medication we're going to give them. Okay, so if they're at a 3 versus a 10, we need to look at the scheduled class of narcotics and which ones we're going to give them. Most dying patients are already on a drip, like a morphine drip or some kind of, pain narcotic drip. But we should still be assessing pain levels.